Oslo as their major person, who years ago, when he went to Johns Hopkins and then came to McGill, and McGill's ashes, Oslo's ashes reside at McGill Library. So we were very much inspired by William Osler to listen, to hear, and to very personal kinds of things about Sir William Osler. And therefore, the clinical training became a key thing. And I also learned by being around in the hospital, training residents in interpersonal skills and doctor-patient communication, where that higher level cognition was very important. Ability to think, ability to diagnose, to solve problems, to perceive certain things were very, very important. And that was my key turning point, and decided that I would not minutiae, analyze the every detail of interaction, started collecting data and observations. Observation, I still think, is the key to think. And I also always believed in science. The education was never had a scientific basis. We just changed curricula whenever we felt like it. We just introduced any technology where we felt like it, or technology was available. We thought it was going to help the students or help the doctors. But evaluating it, understanding what exactly was required, was not available as much. So this kind of made me think that we must do detailed research. Despite the major objection among people, I continued, and that was more than 2 decades ago. And to this day, I still do medical cognition, believing what doctors think, reason, make decisions under conditions of uncertainty, under conditions of complexity. We must stick with publishing. And I absolutely believe no matter what you do, you must publish. And let somebody else out there scrutinize it. Therefore, almost 50% of my papers in the first decade, there was always somebody who rebutted and said, I think there is an alternative view to look at it. And that was also published. And we continued this dialoguing in publication, which is very interesting because I learned something from it, but I also found that if somebody recognizes what you do in cognition, it's also because they think it's important. Otherwise, I can just ignore you. So I have a lot of publications and a lot of students who worked with me over the years, and analyzing these are still to this day, I think. So after McGill University in Montreal, where I was trained, I became professor of medicine and professor of psychology, and I believed that psychology was limited. So we needed to understand the details of language or linguistics, computational work a little bit, computer science. We needed to understand other kinds of AI, because I used to use AI methodology to be able to understand some of the reasoning method. So artificial intelligence, particularly also philosophy and cognitive anthropology. And that came under the realm of cognitive science. So I started that, and I became the McGill director of McGill Cognitive Science Center. And to this day, this cognitive science is what I preach, because and I teach, and I also do research. That means we use the methods from language, computer science, philosophy, whichever area that is most suitable for understanding how doctors and students think and reason, whichever way we use to analyze data. How do people help us understand something, like a patient? And based on that understanding, how do they reason? And based on that reasoning, what do they make decisions? And if something goes wrong in the decision, you need to be able to understand the process by which they do it. Outcome is just not sufficient. You need to link the outcome to process. So to this day, I was recruited by Columbia University in New York, and I built a large laboratory at Columbia, and then I became a chair of the biomedical informatics in Arizona State University. and subsequently I was at Texas Medical Center, also doing the research lab. Now I'm back in New York at adjunct at Columbia University, but I work primarily at the New York Academy of Medicine and have a research lab on cognitive studies in medicine and public health. I still continue to work on it, and I love doing what I'm doing, and I also love to learn from people, like I have learned from you, Dr. Bishwas, and what kinds of things you've been doing, following your work, and I think you and your team are really very impressive. And it's bringing the Australian tradition to more kind of Bloom's higher level taxonomy work on thinking, and in addition to that, also trying to bring in some of the technology, more AI-oriented work, so we're into it as you are analyzing. And I think this is a direction to go, and I really appreciate that, and thank you. Thank you for my long, rambling introduction.
Yeah, I mean, till now it was fantastic. I mean, we could listen to everything. Yeah, it's very, very interesting. Like the conversational dialogue that you have talked about.
I can't hear you, Dr. Rakesh. Oh. Is that just me?
Yeah.
Okay.
Now can you hear me? No.
You're muted.
Okay. Unmute me.
Yeah. Now we can hear.
Okay. Yeah, so it was mistakenly unmuted. So I was just appreciating Professor Patel's interesting observation on the conversational dialogue, which was asynchronously done through publications. I mean, I think most of us have had this opportunity, and we have become so addicted to it that we are continuing to do the asynchronous learning every day through our WhatsApp platforms and emails and everything. So I can see Professor Martin here. She's just joined in from Australia. She is Professor in Monash in Australia, and Professor Martin we have just finished, Professor Vimla Patel has just finished her introduction, and we have Dr. Amy Price, Professor Talukdar here, and our collaborators, Rahul, Avinash, and many others. So we are welcoming you. Are you able to hear us, Professor Martin? Yeah, I think you are muted, so yeah, we need to unmute you. Can you unmute her for some time? Nobody's there? You please call the ID person. To ask him not to go here and there. Yeah.
You can try to unmute yourself.
Yeah. Carmel, you can unmute yourself? Okay, yeah, I think Carmel, you'll have to unmute yourself. Whenever you want to, that is. I mean, there's no rush.
But can you look at the screen? At the bottom of the screen, you can see the microphone icon.
Yeah. Hello. Hello.
Hi.
Yeah, so you are able to hear us?
Yes.
Okay. So we were just saying that Professor Patel has already introduced herself, and we'll be going on with the introduction of the other medical cognition pioneers, and I think next in line is Professor Martin, as we've scheduled it. So Dr. Carmel, would you like to share your thoughts about your experiences in medical cognition, in developing the field?
Well, I feel honoured to be considered in this light by Rakesh. I think that what I've really been about has been the whole process of sense making and complex adaptive systems and personal understanding the systems, the socio-economic, emotional, biological systems in which medical care is enacted. So I've had a long interest in the experience of chronic illness, and there's quite a distinction between illness and disease. And we can constantly are driven by disease models, when often it's illness models that really make more difference to quality of life. But it's a matter of having the sense-making, the balancing between the different trajectories. So basically, life trajectories, health trajectories, biopsychosocial trajectories. So that has been my interest, that we need to, as clinicians, need to tap into the different trajectories that people are experiencing, as well as ourselves in our relationship with them. So I guess that's what my interest has always been, and that's where I've got a bit.
Would you like to talk a little bit about the patient journey record?
Oh yes. So basically, it's very interesting because I'm still doing a lot of work on this. Superutilization is when people go to emergency departments or hospitals when actually their care could have been managed better in the community or at home. So this is where all these trajectories of illness and social need and disease all get muddled up. And so the patient journey record is actually tracking those trajectories. And what we have is lay people who are not health professionals, using a sort of a telehealth system, calling people and engaging with them, like community health workers, engaging with people so that we understand their illness journey, their social journey, as well as their disease journey. And that actually has been proven to make a big difference, because understanding people's illness journey, their social journey, actually helps them to stay better in the community. So we developed an IT system that supports this. So it's person-centered, but it's also semi-structured. And in fact, we think that it might be something that might be useful as in a not-for-profit setting in India. I don't know about that, but it's not. And there's a lot of potential for IT to enhance it, but it actually works at a very simple level. So you call people once or twice a week according to their risk and need, and you help steer them or help support them through their complex health journeys. And you can identify a disease, but it's about illness and people not feeling well and people's care falling apart, not having the social support they need, not having access to services. So that's what the patient journey record is. And we have done a trial, we've done a couple of trials actually, and they've shown that we do make a difference. And then my other work around that is what is this superutilization all about? Well, superutilization is very much a social and ecological as well as a disease problem. The poorer people are, the less resources they have, the more likely they are to have more illness. They're the people who we need to support, educate and ensure that they get the best care in the community so that they don't deteriorate either mentally or physically or socially, so that they need emergency care. So that's the work I've been doing. Any questions? It sounds very simple. It just sounds simple, but it is simple. And it's just regular phone calls. And sometimes there are home visits. It's the community health model. And I think it's got a lot of traction in some countries. And not that my work, but my work is particular work. But I think it's a good model.
yeah, I think your work is combining synchronous communication with a lot of asynchronous communication to help develop medical cognition as a tool to deliver care in the community. So I was just talking about how powerful asynchronous communication has been, as Professor Patel pointed out, in conversational dialogue through journal articles. And I'm sure you, Dr. Amy Price and others have experienced this in their own writings. Like when you publish something, there is an invited commentary. And in our own journals, we have done that with you and I think Dr. Price, where we have invited commentaries on others' articles. So there is a lot of asynchronous learning there, and the same can be done in an asynchronous pager format, which we are currently fully devoted to. And ours uses largely asynchronous platforms like WhatsApp, where we make a pager group for every patient that we come to encounter. And of course, looking at the logistics and feasibility, so we make that pager group and then we follow them up there, asynchronously of course. And in between, there are certain synchronous communication phone calls, as is also very common in your model. So ultimately, we have not looked at it in terms of measurements, but in terms of individual qualitative outcomes, it does look to be quite heartening, and it does keep us going, doing the same thing as currently a pilot. So yeah, I mean, you have inspired us in that way a lot, and we'll of course we'll be coming back. I wanted to finish the introductions, the self-introductions first. In fact, I'm not talking much about you all, because you are all eminently Googleable. So I'm sure everybody knows, all the audience knows about you already. So I just want you to share your work in your own voice. And so with this, I'll move to Dr. Amy Price. And of course, after that, we'll have a very, I'm looking forward to an interesting panel from the audience and from everyone who are online, offline here. So, Dr. Amy Price.
Hi, I'm really honored to be here with you and to have watched the history over the years of other medical students that have worked through Dr. Lee's books. And I think that learning definitely goes both ways, because we learn also, we learn the culture, moving back and forth and working through all of the disciplines. And it's so critical, because in this way we see things that, I see things. I can't really say we, but I see things that I wouldn't have seen otherwise. And I come from a little bit of a different perspective, but have actually experienced several common areas with the speakers. I came originally as a patient, a traumatic brain injury patient, and cognitive rehabilitation wasn't large in those days, so we had to do what we could on our own. And I eventually made it back to a university, learned how to build a model to help myself. And then I was in university with kids, and even though I was injured, I could see how brilliant they were, but they lacked confidence, and they didn't know who they were. They were easily bullied, and they were traumatized in many ways. And what that taught me is the most important thing that we can have in research and in learning is relationship. And if we learn to grow together as teams, and if we learn to value each other, then there's nothing really that's impossible to us. Because even if I don't necessarily have an immediate solution, someone that I'm working with will have an idea, and then from those ideas, solutions emerge. I am also a research editor with the BMJ, and I was there at the beginning when we started with the public and patient involvement statements, patient authors, and co-production. And it was interesting to watch the changes in how research done with patients, for patients, with medical professionals, and patients and researchers working together. This has become transformative. And I remember I went to the DMJ award ceremony. And when I first went, there would be PIs dressed in their best suits. And they would speak for everyone. And they were very proud. They would say a lot about who they were. And then at the end they'd say, and thank you to my team. And that changed. And I watched the last couple of years as PIs, clinicians, and patients brought hand in hand to a podium together and to receive and share an award. And to me, that speaks volumes. I'm currently working at Dartmouth in the co-production laboratory and also research methods. And then another thing I've become involved in is with a large language model of learning and how clinicians and researchers can use that together along with patients for shared decision making. And the people I'm working with there is Jamia and Harvard DCI, but they started with religion. They have a rabbi and they have a minister, and that's how they start. What are the values of AI? Then they brought in patients, clinicians, researchers, and then they brought in the regulators and the legal. So taking that perspective, it allowed each person to see what life was like from a large language model perspective for everyone that used it. And we've been exploring that with each other. What would a regulatory framework look like? Because it's emerging fast. And we're seeing that in a time of uncertainty, that people aren't big come up with like rules and regulations, but the AI is outgrowing those rules faster than they're being developed. And what we need is we need the kind of leadership from our two previous speakers and from Professor Biswas, where you have all done this your own way in India, and that's what we need for the time of uncertainty, where we put people first, and we know that there's uncertainty, and instead of running away from it, we embrace it and make it part of the daily life that we live. I recently watched a challenge where people built a spaghetti tower, and so big groups were given spaghetti, string, a marshmallow. Maybe some of you have seen this challenge, and it was fascinating to watch the groups. You could see the groups that built their towers often and early and weren't afraid to fail, succeeded. And those that built by themselves and then brought their product to the group didn't really function. And so it's a time for transformative learning. That was followed by another kind of what they call like a scrum game. And in the scrum game, you're given several kind of babies or balls, and you're not allowed to throw them. You have to have a leader. You're not allowed to throw someone in either side of you. And process has to be declared. And that's all about when you drop the beaten or the ball, how do you feel? How do you recover? What do you do about it? What effect does it have on your team? And how do you work out? How do you catch things better? And how to pass them on to your teammates? And then, then there's the focus aspect. When there's so many balls in the air as our cognition gets scattered, how do we focus on one thing, one moment we're supposed to be doing in that space at that time and stay alert so we can fulfill that specific purpose and allow the people around us to do the roles that they are in that space and time. And so I'd like to challenge you as members of the medical community in terms of cognition and as students to consider each day, what is my role? What are my boundaries? How can I best fulfill my purpose today? And how can I help the next person do something better? A lot of the successes I think in my life have come because I watched others and I could help them do something that they wanted to do. So I helped them. And what I found out is that's like a seed thing to sow, and when you help others, that help is also available to you, not necessarily, and almost never from the people that you actually gave it out to because they were maybe the people you need. But as in this life, as we sow seed into the lives of others, then that harvest is returned to us in so many unexpected ways. And it's reciprocal, it's beautiful when it gets past some of the challenges that we'll face in life. And so we urge you as medical students to care for your patients, to see them as people. We work on distinctions. No one chooses to be a patient. That is a world that is stress hungry. But behind that patient, behind that disease, behind that sickness, there's a person with a dream and with a vision. And just the way that you treat them in even a few-minute appointment, you can change their life, you can change their vision, and you can give them hope. And I hope also in terms of that we would be willing to do so. And we also agree with our previous speakers about how important it is to publish. I started publishing myself from the very beginning, and the publishing is important because it's when you think by yourself and you're not writing with others, you're not thinking of others, you're not having your ideas challenged, you can only go as far as you're kind of thinking. But when you put your work out there and other people comment on it, other people can improve it. That's the way science grows. It's not about one publication is perfect so no one can say anything. Science changes. And the research shows us that in 20 years, those of us who have studied to be MDs, almost everything that we have learned will become obsolete. There will be new technology, new treatments, new interventions. So the way to stay current is to stay interested, is to stay real, and to make your patients an important part of the way that you live your life, what matters to them, and also at the same time we create boundaries so that you have time, for your families, so that you have time to rest, because that in turn will also make you a better academic, and it will make you a better doctor. So I'm going to leave that with you to think, to think it through, And if there's any way I can help any of you in the future, please let me know. I appreciate you, and I thank you for the opportunity to be here.
Thank you very much. Yeah, I'm sure there will be a lot of inputs on this. Some gentleman called Sam Goodfellow has already given an input. I'm not sure who he is and how he got in as an audience. But yeah, he's given some inputs. And I think it's your line of work which goes towards, from doctors' medical cognition to patients' medical cognition and tries to integrate both is what becomes very, very challenging and risky. Going by the comments we heard in the inbox. So, but then it takes nothing but a Oxford-trained scientist like you to counter all that, isn't it? Because you can stand up to everything, and you have gone through so much in life, so many challenges we have witnessed you, and you've always come out unscathed, and that's really fantastic. Now, when you mentioned insurance, I immediately had Professor Talukdar in mind, who is our next guest, and he has done a lot of work in insurance, and he's still doing, and medical cognition. So he's looking at insurance records, and he's trying to decide what is the medical appropriateness of the care delivery that medical cognitions are providing. Yeah. So we are going to have a lamp lighting song, and lamp lighting, but I don't see our Vice Principal, Honorable Vice Principal, Professor Sudhir is here. And what about Professor Rangarao? He is coming, so shall we wait for him? And once he comes, yeah, he came and left, but he's not going to come back. He's coming back. Yeah. So while he comes back, I'll just like to have something from Professor Talukdar. He is an eminent professor of a very prestigious National Institute of Technology in India. And without further ado, let us move to Professor Talukdar's self-introduction. He is a polymath, physicist by training, computer scientist by profession, and yeah, over to you, sir.
Thank you so much for having me in this particular, seminar or conference. Because maybe myself and Professor Vishwas, both of us are outliers. Okay, I'm an outlier in the sense is that, as Professor Vishwas just said, that I'm a computer scientist by training, and I came to biology by accident. Okay. The reason is that I have seen many cases, and I believe that right care at the right time, for the right patient at the right price, for everybody anywhere in the world is a fundamental right. So the question is, how do we make the right care for the right person at the right time at the right price? And while I was doing that, practically that was not how I started. I started some 45 years ago, and my first publication on AI was in 1980, which is 43 years ago, on Bengali handwritten characters. After that, today, AI is completely different. However, I come from industry. I have been spending my time in industry. I start with new startups, and invariably they will fail after 4 or 5 years, because all of them were much ahead of its time. People laugh at me by saying what I can do. But one thing which is always helped me is that from each and every of them, I learn. And I go to a particular, I'm teaching at NIT, which is one of the top schools in India. However, it's not a medical school. It's an engineering school. And I teach their machine learning. I go to academic institutes to learn myself rather than teaching, because I believe nothing in this world can be taught. Everything has to be learned. So how do I learn? I learn by going to schools and writing papers. The reviewers challenge me, students challenge me, and when they challenge me, I learn. So that's how my journey has been. And also I collaborated with Professor Vishwas, whom I said is one of the very few outliers with a very open mind. When I meet the doctors, I find that majority of them are having a very close, biased opinion about anything and everything. But he is an outlier. I work with him. We had some good amount of work. Coming back to the point is that right now my main focus is in two domains. One is I'm driven by the right care of the right patient at the right time. So what I try to do is that I believe that unless mathematics and computing is integrated with medicine, we cannot take healthcare or disease management to the rest of the population. We are privileged, but not everybody is privileged, and diseases don't happen only to rich and privileged people. Diseases are irrespective. So how to help those who are at remote part of the world who doesn't have a hospital within 50 to 100 miles from their home? How to take medicine or how to take health care to where the patient is? That's the driving factor behind me. And of course medical area, medical firm, and those are driving me to do what I do. So finally, today, other than being industry, I'm in industry because that gives me a little bit of money which I need to use to run my kitchen. However, I always like to be challenged, and I found biology is the only domain which challenges me every day, every moment. The more I learn about biology, I find less I know. Let me repeat the statement. The more I learn about biology, I find less I know. So it challenges me every moment. Right now, I'm working primarily in cognitive graph. That means take the knowledge from various sources, medical, biomedical, and other stuff. Put it in a cognitive graph, and then make that graph available to everybody so that knowledge is becoming normalized and without bias. That's where the challenge is. There are so much of knowledge gap, and in fact, whether it is insurance firm or whether it is medical area, only due to the inference gap, and inference gap has a large factor within the knowledge gap. So how to reduce that gap? That's my current interest. Of course, I'm also collaborating with City of Port, US, primarily for the reason of genomics, which I was in my videos for the club. I started a startup in genomics. After a few years it failed. We started in 2008. In 2017 we had to close it down because it was not taken. Nobody is interested in precision medicine. I'm talking about in 2016, 17. However, right now I'm moving from genomics to spatial biology. As I said, biology interests me a lot. So we are looking at spatial biology, where we are looking at single-cell RNA and other multiomics data, and then integrate it with the clinical data to get the knowledge so that we can have precision health. So my journey today is towards precision health, and insurance is one of the areas because they are the payer. Unless you have the insurance, you are not likely to get the treatment which you can expect or desire. So that's an area, and my recent work have been how to do medical appropriateness and medical necessity. Once again, that is driven by abuse and fraud, which are there in the medical vertical. So, once again, thank you very much for having me here. Primarily, I believe I'll be learning more than sharing my knowledge. Once again, thank you, Professor Vishwas, for having me the opportunity to be with the luminaries like Professor Patel, Professor Amy, and others. Thank you so much.
Thanks a lot, Professor Talukdar. And now we'll have this lamp lighting ceremony. And actually, Professor Rangarao, Professor Sudhir are our vice principals. And Professor Rangarao has done some very interesting work in insurance. I mean, he's doing it every day. So he manages the administration, he looks after the insurance requirements of the patient. And I'm sure he may have some interesting inputs to share after the lamp lighting. So, yes, Professor Rangarao, would you like to talk something about your work on insurance or after the lamp lighting? After lamp lighting. So, I'll invite our senior resident, Dr. Sashikala, and our junior resident, Dr. Harika, to announce the lamp lighting ceremony.
Good morning, one and all. We welcome you to today's CPD on medical cognition, blooming real patient hospitals. Now we request Dr. Rangarao sir, Vice Principal Academics, to come on to the dais. Dr. D. Sudhir Babu sir, MS, Vice Principal of Academics, to come on to the dais. Dr. B. Rakesh Biswas sir, HOD of General Medicine Department, come on to the dais. Dr. Aditya sir, AIG consultant, to come on to the dais.
Now we request all of you to join the lamp lighting session that will mark the beginning of our CTV. This symbolic ceremony is a beacon of enlightenment, representing the illumination of knowledge and the spirit of togetherness.
Now we request Dr. Rangarao sir to speak a few words.
Good morning, everybody. It's really a very fabulous day to see the Department of General Medicine working very hard on this, especially something digital way. I'm very happy for this. It's something advancement in this something innovative thinking from Dr. Professor Biswas. Really, thank you very much, sir. Really good thing, and I hope things will go on. And from other departments also the same. And I wish a great success of this the conference. And as sir was asking me to inform related on the insurance, there is nothing. We have got insurance fairly, the government has been sponsored one, RHC one. And RHC is the one which is not there, but now it's from 2007. It is in combined AP it is there. And started with some very few of the diseases covered. And later on now it has gone almost 1,000 diseases that have been covered in this. And all the departments, all the sectors, all the medicine, surgery, what at all, even including the DVL also, certain diseases have been covered in this. And government will fix certain packages for that. We have to treat the patients accordingly. And as per the norms of the government, we have to look into the patients and they treat them and then send them, even give them their transportation charges also. So especially those people who are having some chronic diseases like CKD and people who are having MHD dialysis and continuous dialysis are there. Those people are being taken care very well. And all over the state there are many, almost every district nowadays they are having more than 4-5 dialysis centers. And previously it used to be only higher centers like Gandhi, as I know there was only Gandhi and Usmania only it has started. And later on now it has gone into the Harvard level also. So this is the progress of our government sector. This will continuously completely be and sponsored by the government, and the premium is paid by the government for all the below poverty line people. So this is the way how the governments are functioning in both the states, both the Telugu states, that is both AP and Telangana. And so suddenly we would say that we must feel proud of this, proud of the introduction of this program of Arabistry, that is insurance program. This government sponsored insurance program. And besides that, we are having Arabia Bhadrata, which belongs to the policemen, and other insurances are that are covered by private insurance. So also we are following that, we are giving to the public. And besides, in-house we have got one, that's Kamineni Arabia from the KAP, that's program that is where will be limited services will be giving, that is about total all the investigations to the extent of 1.2 lakhs that we will be giving. This is covered for 3 years, and 1.2 lakhs amount of the people for the poor people. Whoever that place, there is no any bar for anybody can join. There is nothing like any economical barriers for this. Anybody who can pay 3,000 rupees and will become a member, and then all the people will be given some benefits from the both that in our hospital. It's only for Kamineni Marketpalli and dental services. Both are included, and totally for 5 members in that who are registered in that program, to the extent of 1.2 lakhs will be covered. All the investigations are free and consultations are free, and the pharmacy is about some 20% will be reduction will be there for the hospitals. So this is about what we are following and what we are doing in terms of this insurance program. As Professor discussed related what, and we always look into the people who are very poor people. Most of the people that are coming, and besides this insurance program, most of the patients we are giving them free of cost. Almost we can say 95% of the patients are being treated free of cost in this hospital. So this is the way how we are helping, rather serving the society around this hospital. With these words about what we are doing in terms of this insurance and services to the people, and coming to this conference, really I am very happy that I hope that it will become very, very, very successful. thank you for inviting me for this, and all the best to you, everyone.
Thank you, sir. Thank you for enlightening us about the insurances and how it works.
Now I request Dr. Aditya sir to chair the first session. It is a great pleasure that I stand before you today to introduce a distinguished member of our alumni, Dr. Aditya sir. He serves as an inspiration to the current students and fellow alumni. Without further ado, please join me in welcoming Dr. Aditya sir. We look forward for hearing more about his remarkable journey and the insight he will share with us today. Thank you.
I think Aditya wanted to present his slides at the end of the session, isn't it? And this one I thought was Aditya just talking about, as a member of the dais for this session, the light lamping. I thought you invited him to say some, like you want to just comment on whatever has the speakers, the previous session speakers have done. And I was also hoping for a little bit of questions from online audience as well. So first over to Aditya and then the online audience. Yeah.
Thank you. Thank you for inviting me. It's a mixed feeling coming back here. I'm coming back in the capacity of being a consultant now in AIG, and I am what I am today because of the institute and largely because of Viswasa. So I think once I'll be able to chair the session and come in with my presentation, I'll be able to add more. So for now, I just want to thank you for inviting me.
So any other inputs from the previous session where we just introduced the pioneers, and we were hoping for some more inputs and discussion, but yeah, of course this will just continue asynchronously over time. And we have kind of finished 1 hour of the previous one, so I think we can start with the next session of medical cognition, which is around rheumatology, and we have quite a few speakers, and I'll ask Dr. Harika to introduce them.
Now, the first session is rheumatology session. Grooming real patient off case in rheumatology. And the first case is presented by Dr. NAVYA, second year postgraduate, Department of General Medicine, a case of SLE with pyoderma gangrenosum.
Handle that slides.
Oh,
Right.
Good morning everyone. I am Dr. NAVYA, second year postgraduate. Today I am going to discuss about a case of chief complaints. A 25-year-old female resident of Annaram village, homemaker, came to the casualty with chief complaints of fever since 3 months and pain abdomen since 1 month. And history of presenting illness. Patient was apparently alright 4 months ago. Then she developed amenorrhea. And history of fever since 3 months, which is insidious in onset and gradually progressive, high-grade, intermittent in nature, associated with chills, and which is temporarily relieved on medication and not associated with any cough, cold, or burning micturition. And history of pain abdomen, which is diffuse in nature, dragging type, non-radiating, associated with bloating and tightness, and weight loss since 3 months. Joint pain since 3 months, history of hair fall since 3 months, and hyperpigmented patches over the chest since 1 month. And no complaints of vomiting, loose stools, and history of shortness of breath since 1 month, which is grade 2, and insidious in onset, gradually progressive, and aggravated on exertion and relieved by taking rest, and not associated with orthopnea, PND, or palpitations. Not associated with pedal edema or decreased urine output, and history of 2 episodes of generalized tonic seizures 5 days back for about 2 minutes with uprolling of eyes, eyeballs, lip bite, and no involuntary micturition, defecation, or frothing from mouth. And past history, patient had a history of butterfly-shaped hyperpigmented patch over cheeks 3 years back during her pregnancy. And she is not a known hypertension, diabetes, CVA, CAD or TB, bronchial asthma, thyroid. Personal history, appetite decreased, diet mixed, sleep adequate, bowel and bladder habits are regular, and no addiction. Menstrual history, LMB in June. Age of menarche 14 years, and previously regular cycles, and since 4 months she is having amenorrhea. And general physical examination, patient is conscious, coherent, and cooperative, and patient is thin-built and poorly nourished. Alopecia is present, and hyperpigmentation over chest present. Multiple ulcers over elbows and legs present. Pallor present, and no signs of icterus, cyanosis, clubbing, lymphadenopathy, or edema. And this is the image of the patient showing her thin bill. And this is the image showing her alopecia. And this hyperpigmented patch over the chest. And pallor. Vitals at the time of presentation, BP is 120/80. On right arm supine position. And pulse rate is 140 beats per minute, which is regular, good volume, no radial or radiofemoral delay, and temperature is 101 degrees Fahrenheit. Respiratory rate is 20 cycles per minute. Her saturation is 98% on room rate. GRBS is 80 mg per deciliter. And systemic examination, per abdomen inspection. Abdomen is scaphoid and umbilicus is inverted. All quadrants are moving equally on respiration, and no visible pulsation, engorged veins, scars and sinuses. And on palpation, no local rise of temperature, soft, tenderness in right iliac fossa, and no organomegaly, no other palpable masses. And percussion, tympanic note heard, no shifting dullness. Auscultation, bowel sounds are heard. And respiratory system inspection, chest is elliptical in shape, bilaterally symmetrical, trachea is central, movements are equal on both sides, no scars, sinuses, and visible pulsation. And on percussion, all areas are resonant on percussion. Auscultation, normal vesicular breath sounds. Cardiovascular system, JVP not raised, apex beat palpable at left fifth intercostal space, half-inch medial to mid-clavicular line, S1, S2 heard and no murmurs. CNS, no focal neurology. Provisional diagnosis, 25-year-old female with pyrexia of unknown origin, cachexia, arthralgia, seizures and multiple ulcers. Differential diagnosis may be infective or autoimmune cause. And investigation, hemoglobin is 5 gram per deciliter and total count is 10,000 cells per cubic mm. RBC is 1.81 and platelets are 2 lakhs per cubic mm. And LFT total bilirubin is 1.30, direct is 0.40 and AST is 80, ALT 20, ALP 667 international units per total protein is 5.8 gram per deciliter, albumin is 1.83 and CUE albumin is +1, pus cells 3 to 4, blood urea is 20 mg per deciliter, creat is 0.7, sodium is 125 milliequivalents, potassium is 3.9, fluoride is 96. APTT is 30 seconds, PT 15 seconds, INR is 1.11. And these are serial electrolytes showing sodium 125, potassium 3.9 and fluoride 96. And peripheral smear, RBC is normocytic, normochronic and WBC counts are increased on smear with neutrophil predominant, platelets are adequate and reticulocyte count is 0.5% and serum iron is 75 microgram per deciliter. And CRP is positive 2.4 milligrams per deciliter, ESR is 130 ml per first hour, LDH is 200 international units per liter, direct Coombs test is positive. Serum osmolality is 242 milliosmoles per kg and urinary chloride is 138, urinary potassium is 12.4 and urinary sodium is 84. And 24 hours urinary protein is 82 milligram per day and 24-hour urinary volume is 1000 ml and spot urine protein creat ratio is 0.32. And 2D echo ejection fraction showing 51% and IVC size is collapsing. RWMA present, anterior wall hypokinesia and no AS or MS and good LV function and no diastolic dysfunction. And USG abdomen and pelvis showing grade 1 fatty liver with mild ascites and internal echoes noted in bladder which is likely cystitis and right mild hydroureteronephrosis. And this is a AMA profile showing the dsDNA positive and SSA positive and the SSB is positive. And this is a chest X-ray. And this is a ECG showing sinus tachycardia. And these are the images of ulcers on the left elbow. And this is the ulcer on her leg. Multiple ulcers on the legs. And this is a fever chart showing the high-grade fever spikes. And blood culture and sensitivity shows contaminants growth, no growth after 24 hours of aerobic incubation. And urine culture, polymicrobia flora growth. And DVL referral was taken in view of ulcer. Biopsy was done and it showed as pyoderma gangrenosa. And treatment given is a injection bonus of 1 gram BD and tab HCQ 200 mg BD and she was started on oral steroids which is prednisolone 40 mg per oral OD. And the final diagnosis is systemic lupus erythematosus with pyoderma gangrenosa. And current state of the patient is on tablet prednisolone 10 milligrams OD and tab HCQ 200 milligram BD. Joint pain has been reduced and no fever spike, hepatite has been improved and she gained 4 to 5 kgs of weight and ulcers are healed. These are the latest images showing the healed ulcers on the elbows and legs. Thank you.
Aditya sir, would you like to add any points regarding this case, sir?
So, first of all, well presented on the sequence of events. I think there were a few other portfolios on the same patient, one of which was Dr. Is not a doctor yet, he's probably a final year student. So, Asjad and Rakshita, we took a full history of this patient, and what came out in that was she was most concerned about concerned about social seclusion because of the ulcers. And the other aspect was that she was unable to interact as much with her children because there was a false belief that this was a contagious disease. And I think this narrative could have been brought out better. And I think those two narratives showed that she was most concerned about these aspects. So I think we have to address these aspects. And I think I'll show it in my presentation of how HCQ or hydroxychloroquine can make her closer to her children. I am looking at it that way. This is one form of evidence-based medicine I'm looking at. So can HCQ not just treat her inflammation alone, but can it bring her closer to her children and evade her social seclusion? But otherwise, I think the entire presentation from a clinical aspect was well done. So, good job.
Thank you, sir. Now we welcome second case presented by Dr. Lohith, second year postgraduate, General Medicine Department, to present the case of SH vasculitis.
Good morning everyone, I am Dr. LOHITH, second year postgraduate in the Department of General Medicine. This is one of the case in the series of rheumatology case presentations. So, a 25-year-old female, housewife by occupation, resident of Nalgonda, came with the chief complaints of multiple joint pain since 3 years, facial puffiness since 2 weeks, and fever since 2 weeks. Patient was apparently asymptomatic 3 years ago. Then she developed multiple joint pains involving large and small joints with no swelling of joints, intermittent in nature. They used to disturb her daily routine household activities and had no morning stiffness. She also developed fever since 15 days, which was low-grade fever, not associated with chills and divers, intermittent in nature, no diurnal variation, believed not taking medication. It was not associated with cough, cold, vomiting, loose stools, burning irritation, and pain abdomen. It was associated with headache and generalized body pains. Headache was frontal region, intermittent in nature, and relieved on medication. Patient was complaining of shortness of breath since 3 days, which was present in ordinary activity, mainly during the episode of fever, and no diurnal variation. No complaints of orthopnea, paroxysmal nocturnal dyspnea, profuse sweating, chest pain, palpitations, or these. Past history: patient is a known case of hyperthyroidism since 5 years. On tablet levothyroxine 25 micrograms orally once a day. She has history of usage of steroids for her multiple joint pain since 3 years intermittently. There is history of 3 abortions previously. 2 in first trimester and 1 in second trimester. 2 complete spontaneous abortions in the first trimester, and medical termination of pregnancy was done in second trimester as a fetal heartbeat was absent. Not a known case of hypertension, diabetes, mellitus, coronary artery disease, cerebrovascular accidents, tuberculosis, asthma, or seizure disorder. Family history, no significant family history. Personal history, mixed diet, sound sleep, appetite adequate, bowel and bladder habits regular, no addictions. Menstrual history, she had regular menstrual cycles. General physical examination, patient is conscious, coherent and cooperative, well-oriented to time, place and person, moderately built and moderately nourished, pallor and anasarca was present, uterus, cyanosis, clumping and lymphadenopathy were absent, JVP not raised. Vital cell presentation, temperature 100 degrees Fahrenheit, pulse rate 92 beats per minute, regular, normal volume, blood pressure 130 by 70 mmHg, right arm in supine position, respiratory rate 20 cycles per minute, SpO2 98% on room rate, GRBS 132 mg per day. Systemic examination. On inspection, chest is elliptical, bilaterally symmetrical, trachea is central in position, chest movements are symmetrical on both sides, no scars, visible pulsation, apical impulses not seen. Palpation, all inspective findings are confirmed, no local rise of temperature, no tenderness, trachea central, chest movements are symmetrical on both sides, tactile local temperature normal in all areas. Percussion, resonant note heard in all areas. Auscultation, bilateral air entry present, normal vesical bed sounds heard, no added sounds. Cardiovascular system, on inspection, chest was elliptical and bilaterally symmetrical, apical impulse not seen, trachea appears to be central in position, no visible pulsation, enlarged veins, scars, sinuses on chest wall. On palpation, apex beat palpable at left 50 intervals in space, half inch medial to mid-clavicular line, no palpable eaves frills present. On auscultation, S1, S2 heard, no murmurs heard. Per abdomen, scaphoid shape, abdomen, no visible pulsation, enlarged veins, scars, sinuses, soft, non-tender, no guarding and rigidity, no alveolomegaly, bowel sounds present. CNS, patient is right-handed, higher mental functions, patient is oriented to time, place and person, bilateral pupils normal in size and reacting to light, cranial nerves were normal, signs of meningeal irritation. Initially there was no neck stiffness. On day 5 of admission, patient developed neck pain, following which she had neck stiffness, but curvings and buoyancy signs were negative. Sensory system normal, motor system power 5/5 in all 4 limbs, tone normal in all 4 limbs, reflexes were present in all biceps, triceps, supinator and knee and ankle were present, plantar flexion in both limbs. Joint examination, general appearance, no swelling or deformity were present. On inspection, there was no redness, scars or rash. On palpation, tenderness present in bilateral, DIP and PIP joints. No effusion, no warmth or temptus were present. No restriction of movement. Provisional diagnosis, initially we thought it was arthropathy with Cushing syndrome secondary to use of steroids, pyrexia and evaluation, anemia and hypothyroidism. ECG shows sinus tachycardia, normal sinus rhythm. Chest X-ray, trachea appears to be central. USG abdomen, there was left renal calculus in 3 to 4 mm noted in the lower pole of left renal. Investigation, at the time of presentation, FB was 9.6 gram per DL, THC was 13,400, platelets were 2 lakhs. On CUE, albumin was 2 plus. 24-hour urinary protein was done, which showed loss of protein more than 1 gram per day. On investigation, serum creatinine was 1.6, blood urea was 88. In total bilirubin, there was serum albumin was low, which was 2.4 gram per deciliter. Post in the hospital, 25-year-old female housewife, resident of Nalgonda, presented to the casualty with the above mentioned complaints. Initially, as the fever spikes were present, we thought it was of infective etiology and we treated with injection monostat 1 gram IV BD for 2 days. Following which, as the fever spikes were continuous and there was raised THC counts, we escalated the antibiotic to injection piperacillin plus tazobactam 4.5 gram IV BID for 5 days. Following which the counts reduced and even the fever spikes subsided. As she had usage of steroids for 3 years, we suspected patient to have steroid-induced Cushing syndrome, and tablet prednisolone was still continued. Tab prednisolone 5 mg POD daily. ESR was 100 on the 15th of December. On 19th it was 130. CRP was positive. Rheumatoid arthritis factor was negative. As the patient has history of multiple joint pains, ESR and CRP were raised. Rheumatoid factors are negative. Patient was clinically diagnosed with seronegative arthropathy, and ANA profile was sent. Tablet hydroxychloroquine 200 mg POBD was started. These were the X-rays of the hands. ANA profile was sent, which shows positive for SSA, RO60 was positive, SSB, LA antigen was positive, and SSA, RO52, which were mainly indicating patient had indicating Jordan's positive. After 5 days of admission, patient developed neck pain, and there were no fever spikes at that time. Orthopedic opinion was taken for the neck pain, and they said there was no active intervention from their side. On the same day, as we had the neurologist coming on Thursday, we took neurologist opinion. As the patient complains of neck stiffness and there was bilateral eye abduction restriction movement, patient was suspected to have nasal intracranial tension, and suspected to have patient to have aseptic meningitis or benign intracranial hypertension. Sir advised for MRI brain, fundoscopy and lumbar puncture. These were the X-rays of the neck. Orthopedic consultation was taken, no active intervention from their side. Neurology consultation was taken. Ophthalmology consultation was taken for review of raised ICP. There was no evidence of raised ICP. MRI brain was done. It showed acute infarct in left paramedian pons and old infarct in bilateral steatocapsular regions. Following the MRI brain, patient was started on tablet ecosprin 75 mg orally once a day. At the time of discharge, patient fever spikes were absent, neck pain was reduced, patient was discharged in hemodynamically stable condition and was asked to take rheumatology opinion and review to general medicine OPD after 1 week. These were the investigations at the time of discharge. Total leukocyte counts were subsided, but creatinine and urea levels were elevated. Serum albumin levels were normal at the time of discharge. Our final diagnosis at the time of discharge were query Jordan syndrome, query systemic lupus erythematosus or mixed connective tissue disorder, vasculitis with acute infarct in pons, Cushing syndrome, seronegative arthropathy, anemia of chronic disease, and hypothyroidism. Advisor discharge, tablet prednisolone 500 mg OD once a day at 8 am for alternate days for next 5 days. Tablets hydroxychloroquine 200 mg PD 8 am 8 pm for 15 days. Tablet levothyroxine 25 microgram at 7 am. Tablet ecosprin 75 mg POD at 8 pm once a day. And tablet Alderset half tablet PO for next 2 days. Tablet Dolo 650 mg PO SOS. Clinically, patient was the considered patient who had SLD with mixed connective tissue disorder. After the discharge, patient went to government hospital LIMS, after which she developed 346 cranial nerve palsy, and patient had complete loss of vision, complete blindness, and patient was intubated there. Thank you.
Now I request our HOD sir to give some inputs regarding this case. Dr. Aditya sir, we request you to give some inputs regarding this case.
Thank you again. I just want to reframe the problem here, and I also request inputs from the audience. First of all, well presented. Thank you. 25-year-old female with recurrent abortions and thrombophilic events, what would you think of? Anyone from the audience? Yeah, so I was thinking APLA was a very likely possibility which wasn't mentioned, and there is also a possibility that she may have had non-infective endocarditis or non-bacterial endocarditis, perhaps which explains the fever. Was there any consideration of endocarditis at any point?
Yes, sir, it was a possibility, but we did 2D echo and it was normal.
I don't think
And the
the
criteria
is
was-
sensitive to pick that. Is there anything else you could have done? I mean, I'm just thinking aloud with you. Anything else we could have done?
Cultures were normal, sir.
Yeah, that's what I'm saying. It's
Let and urine
non-bacterial.
Non-bacterial.
You could have expected just clots without bacteria, because assuming it is APLA, so you would expect sterile clots. So you wouldn't expect cultures positive. Anything else we could have done here? And perhaps the progression, constant progression of developing cranial nerve palsies is fitting in with some thrombophilic disease spectrum, which also probably precipitated recurrent abortions. So, is there anything else we could have done? Perhaps? Anyone from the audience? Yeah. This is not a question and answer session, it's just medical cognition.
Actually, there's a continuation to tell about this patient.
Okay, great, good.
Good morning everyone, myself Dr. Haripriya, final year postgraduate in the Department of General Medicine. Today our topic is about blooming real patient hospice in acute neurological syndromes and recovery. Coming to the case, about the 25-year-old female case which Lohith had already discussed. She's a 25-year-old female who presented with fever and neck stiffness, and we initially suspect meningitis. And urine and blood cultures were also sent, but initially the patient attenders denied for lumbar puncture, so it wasn't done. And as already discussed about this, IV antibiotics were started, and as continuous fever spikes were present and DLC counts were raised, antibiotics were escalated. And we thought of steroid-induced Cushing's as she was on Visalon for 3 years. And in view of multiple joint pains and her ESI and CRP were raised, RF factor is negative, we diagnosed her as seronegative arthropathy, and ANA profile was sent, and we started her on hydroxychloroquine. As patient was discharged in a hemodynamically stable condition and was asked to follow to GMOPD after 1 week. And the course in outside hospital, they done lumbar puncture for her, but the result wasn't significant. She also developed 346 cranial nerve palsy. They thought it as benign intracranial hypertension. As her sensorium was deteriorated, patient was intubated. And they started her on steroids, thinking it as SLE vasculitis or Sjogren's vasculitis. And then there is no improvement with steroids, and they also started her on IV immunoglobulins. And even after, initially there was an improvement after starting IV immunoglobulins, but laterally her condition got worsened and she expired after 1 week. And this is the criteria. They thought it as catastrophic APLA, which worsened her condition. And these are the criteria fulfilling APLA in clinical criteria and laboratory criteria. Clinical criteria is vascular thrombosis greater than 1 episode of arterial, venous or small vessel thrombus in any tissue or organ. As we can see in her, there is an acute infarct in there is an acute infarct in pons involving her brain here. And she is having pregnancy mortality greater than 1 unexplained deaths of a morphologically normal fetus beyond the 10th week of her gestation. And in the laboratory criteria, lupus anticoagulants present in plasma on greater than 2 occasions, but it wasn't done. Anticardiolipin antibodies of IgG or IgM isotope in medium or high titer, or anti-beta-2 glycoprotein 1 antibody of IgG or IgM isotype. And definitive APS is present if at least one of the clinical criteria and one of the laboratory criteria are met. So this is about the first case.
How in hindsight do you think this is happening? You think so? Okay. So I think so when was this consideration first entertained? So when did you first consider it?
At the time of discussion only we thought it as after.
Okay. Okay, so perhaps we could have probably started on, I'm not sure we could have saved this patient. And by the way, you mentioned IV steroids. Can you go back 2 slides? Yeah, next. Started on IV steroids. So what IV steroids were given?
They started on prednisolone itself. Documentation was not available. I asked them orally.
Okay. So it was not a pulse therapy, not the standard 1 gram or 750 mg methylprednisolone. It wasn't that, right? Okay. So if, let us say, a similar patient presented again, what would you and I do differently? This is reflection. We are learning from our past cases. So what would you do differently?
Pulse therapy.
Okay. And so is there anything we could have done which could save this patient? Because I am just thinking warfarin and I'm not sure if it will save the patient. But is there anything which can save this lady, young lady, and she's mother of a few children, I'm assuming, in the background of recurrent abortions? So what could anyone from the audience or even sir can join us? What can we do to save her? Because there is loss of human capital. A young lady has lost her life. At some point, maybe one of us can be in her position. So I empathize with the situation, but can we have tried pulse therapy? Can we have tried heparin? Can we have tried warfarin? Or can we have tried anything else? Or maybe HCQ was a bit suboptimal. Can we have gone all guns blazing, given methotrexate or rituximab, something of that sort? Any thoughts on that from anyone? Sir, if you can please share, sir.
I congratulate the speakers and the audience for the patient listening, and the way they delivered was very nice, very well coordinated. So what we have in all these patients' stories are a sequence of events. Actually, I am still preparing a position paper on our thesis on events, outcomes, comorbidities, and I am still unable to publish it, but as it keeps on getting more and more interesting, as I keep reviewing the literature, so I am still holding back. Now, if we look at the sequence, I think Aditya, what he has in mind is absolutely in sync with what I was thinking. Like, if you can go retrospectively and look at the entire picture of how the events unfolded in this human being, this one, that one, and so many that we are going to discuss today. Is there any time point where we could say that something, some solution, some intervention at this point may have turned the balance in favor of life rather than death? I think that's what we had in mind. So, of course, the first step would be to graphically represent the sequence of events. Like if we see the timeline, where do we get an inkling that something is going bad? something is brewing, a storm is approaching, a dark cloud with a silver lining, much at a distance. So at some point, maybe with the first pregnancy, maybe with her marriage, who knows? There's so many things going on as a woman grows. She grows into an adolescent, then she marries, and then there's so many things happening in her life, and which are influencing her body. Whatever these more than 10 trillion cells are, they're working in unison. Some of them are doing the work of our heart, cardiology, some of them are working for our entire CNS, neurology, and so on and so forth. You get the drift. So, these cells are, although they seem to be sessile and they seem to be static, they are also, evolving dynamically. And some of them are dying off, some of them are getting reborn, and everything is getting programmed with the genes. So, what is happening in this trillion cell system which made it self-destruct at a point? Because as Arita pointed out, non-bacterial thrombotic endocarditis, a very classical feature of SLE, which is first blocked by Mr. Lippmann and Sachs, isn't it? So we know that there is something which is intrinsically wrong with this trillion cell existence, which is trying to self-destruct. So where does that activate, and how do we switch off those genes? So I think we have come to a certain point now where we are talking of microRNA therapy for these kind of things, where we can reprogram the genes. Because ultimately it's all about activation of the genes, setting up a cascade of events, cellular events, which are causing the self-destruct. So if we can reprogram the genes using whatever we know about them, as in microRNA, the building blocks, which can somehow, reprogram it. We don't know a lot. Some people may know much more. But still, the entire collective cognition around this solution business is quite less. And all we have is immunosuppressants. As Arita pointed out, could we have given some very strong immunosuppressant at some point where it could have made a difference? Well, it's very difficult to answer that question. So I think I'll rest my case here. I want the senior residents to also speak. I thought Manoj was supposed to be chairing and Arita was just the global expert. Manoj was supposed to be sitting and conducting that, but I think his work was taken up by Harika. You outsourced your work. But now let us hear from you a little bit of input. Do we have another mic in that side? Yeah, Harika, give him the mic.
Good morning, everyone. Sir, to sum up this case, as they have already presented, Dr. Lohith has presented well actually. One more thing is, the patient came to us. One more thing they have missed is, she also had some involuntary movements of her neck, like titubation type of movements were there at the point of presentation. And then later on, when we have examined her and asked for the history, clinical history, she was like, from the past few years, I have multiple joint pains, and also I have been going to some R&D doctor and he has prescribed some medications which I have stopped abruptly. And then later on, she had some anasarca type of features and also this titubation type of movements in her neck, and also some fever spikes for which she came to us. And then initially we thought of some differentials, like hypothyroidism is the one thing which already diagnosed, and the second one is rheumatoid arthritis, which is obvious, like multiple joint involvements, and also there is some DIP sparing. So we have thought of rheumatoid arthritis too, sir, and the Cushing syndrome was already there. So we have started her on steroids, and then we have sent some samples for C-reactive protein and all. Then they got to be raised, and the RA factor was negative. Then we thought of seronegative arthropathies, and those seronegative arthropathies to diagnose, we have sent some autoimmune profile like ANA, which got up to be positive. Then even before that,
when we started her on hydroxychloroquine, the next day when we started her on hydroxychloroquine, she was absolutely fine. She was like, on the day of presentation, she was like, she was unable to move. Then the next day when we started her on hydroxychloroquine, next day morning she was absolutely fine and she was saying that, I'm okay sir, just I'm having some fever spikes, that's it. Then we have also, after the ANA profile, we thought of starting something else like you said, without Rexate and all. But on the fourth day itself, when we examined her, and I just casually during my rounds I have just wished her. So I have observed specifically she developed stool, which was not there on the first day. Then we got a alarming thing and we have went for MRI and neuro sir's opinion and everything. He also suggested that there might be some chance of non-bacterial meningitis, aseptic meningitis, or there might be a chance of steroid-induced meningitis, for which we have asked for to go for CSF examination, for which they have rejected actually. Patient attendants we have explained them, still they haven't given their consent for that. But later on, when we have seen the MRI and there were some hemorrhagic spots present on pons and all, then later, after 2 days, we have continued the same therapy with the steroids and hydroxychloroquine. And then when the patient felt better, we thought this is the best time to refer her to a rheumatologist who can give a suggestion and can continue the treatment if needed. So we have continued her on both steroids and this, but not on the higher dosages, only in view of this. But even in the first days, we have kept APLA also, sir, as there was. So we have sent her and we have just taken up the further thing like what is happening in the NIMS and all. There the rheumatologists have admitted her and they have kept these things as like SLE with vasculitis, as Sjogren's and APLA as their working diagnosis. Later on she developed her loss of vision, which was gradually in progression, and then finally she developed some respiratory distress and she went on to intubation, and few days back, 2 to 3 days back, she expired, it seems. So they also have these 3 working diagnoses. So we wanted to know from you, sir, actually, being a physician, if we encounter these kinds of patients in a setup like this, what are the drugs which are patient friendly and doctor friendly, to be frank, to start?
First of all, very well explained, sir. Thank you so much for clearing the sequence of events. So yes, in fact, just to go back and think of the anatomical pathway, there is only one organ system which has access to all other organ systems in the body, which is the cardiovascular system, your blood vessels. Your blood vessels have access to all other organ systems, and therefore when you see multi-system inflammation, very rightly pointed out by Dr. Manu, you think of vasculitis, because that is the only system which has access to the kidney, injuring the globule, causing the proteinuria, and injuring your paramedian pons and causing an infarct. So I think I agree with you, you did consider vasculitis, but what remains unexplained is the spiking fever. I think the chart was like a picket fence. I don't know, I'm just making up words. But it cannot be explained by the renal dysfunction alone or the infarcts. So perhaps with consistently negative blood cultures, we are probably looking at, I'm pivoting towards endocarditis here. So,
even though it's if you are thinking of non-bacterial endocarditis, there might be some presentations like vegetations and all. There should be something.
And again, it depends. Ultimately,
the one who does the
Dr. Madhavi is also here, is dependent on the hand which is holding the brain.
Exactly.
Yeah. Just like the patients who come to us are depending on the brain we have. It's ultimately a give and take relationship. So At the hospital I am working in, at the blink of a finger, we can get a TEE, transesophageal echo. So, of course, I have been here for 3.5 years and that's not possible. So, we have to rely on hunches perhaps, that I think this is endocarditis and I may have to probably, I don't know, I probably would have gone with the pulse therapy here, methylprednisone.
So if this was non-victal endocarditis, what would have been our best approach given the current thinking, cognition and solutions available?
When I was the an SR here, we reviewed the literature on warfarin versus ecosprin because she was started on ecosprin. Warfarin precipitated 0 thrombovascular events in 1 year, but ecosprin had 12 to 15. So I would have pivoted towards anticoagulant and antiplatelet. And I don't see any harm in taking a pulse therapy with some antibiotic cover. She anyway received piptazamazine, piperazolone tazobactam. Yes. So you had the cover, and perhaps, even I don't have the experience, but you could have, or we could have tried a pulse therapy. Even to treat anyway there is an indication for the kidney disease. You could have tried the pulse therapy. I don't know what outcomes it would have brought, but one indication as renal vasculitis or glomerulonephritis, you could have tried the pulse therapy is what I was thinking. And a bit higher immunosuppression. Maybe joint involvement always, in my mind, brings methotrexate. I don't think there is good efficacy for HCQ in joint involvement. But again, she did not have any erosions or...
No, sir.
Yeah. So these are my 2 cents.
I think it's a very, very important input that probably what did her in a catastrophic manner was the multiple thrombosis in the multiple vessels that were in play. So, as you rightly pointed out, most importantly, a combination of anti-inflammatory immunosuppression along with anticoagulation. So, I think perhaps that came too late. And also, when we have a situation like this, we can't really predict which side it is going to go and when. If we start those anticoagulants and immunosuppression, at which point of time will it be useful in the sense that we will not lose the patient?
Just to the fact that you referred her to a rheumatologist doesn't mean that the best outcomes are guaranteed. I work in an empire of gastroenterology and I still see them fumbling, latching onto poor diagnosis and all. So it's ultimately your thinking capacity, which is a very bedrock of this conference, medical cognition, which has the best possibility to bring the best outcomes. It's not the availability of the expert who actually doesn't have time. They have to see hundreds of patients. So, rightly, there is a reason for referral, but all I'm saying is outcomes are not guaranteed with the referral. That's all I'm saying.
Yes, sir. Actually, the thing is, when we have already referred the patient also, even at rheumatologist, even under the rheumatologist care, the patient got worsened.
Exactly.
That's the point you have explained that.
Yes. Because I don't think they have the time and the cognitive effort to busy themselves. So this is the very problem plaguing our healthcare system, which was published recently, that 72% of all healthcare facilities are concentrated for 27% of India's population. So all our hospitals, all our elite hospitals are densely populated in cities. And this is causing such kind of problems where there is no availability of expertise in peripheral areas.
Sir, one more thing. One of our pioneers from online, she have asked for Carmel Martin, ma'am. She has asked some doubts in the chat. She asked patient's journey in the community before the final presentation. So, actually, sir, the prayer history before this, the patient was absolutely fine before 2 weeks actually. Apart from her joint pains, except for that complaint, nothing else was there in that patient. And also, the patient just before presenting to us, just 1 or 2 days before presenting to us, she got sick, and she was like, she developed that neck titubations type of thing, for which they were so much, I mean, like, they felt this has to be seen by a doctor. And then they have visited the hospital. And the second question they have asked here was why the patient was referred to a rheumatologist very lately. Ma'am has asked, pointed out. The thing is, when we, as you know, sir, in these kind of hospital setups, all those ANA profiles and all, getting those reports and making a diagnosis itself takes some time. In our setups, to be frank, it's not that fast. So might be those things have got to us lately. Yes, sir. That means, I mean, clinically we cannot directly diagnose those
And you have to agree that I have hindsight bias. I'm sitting in a quiet environment.
Exactly.
I have the opportunity to think freely.
Yes.
If had I seen the squint myself, I would have panicked perhaps.
True.
That's possibility. So only thing we can do is reflect and learn, which is what's happening. So it's good that a very well-made presentation was made by Lohith and Haripriya. So, and thank you, sir.
Thank you, sir.
And I also had this very nice point about the diagnosis being made on the basis of the antibody, which is not very easily available. So, what difference would it have made if it was not available? I mean, let's say the patient came to us, didn't have the antibody, didn't have the story about APLA, and what would have happened differently? Just to put it in another way. Well, of course, she went into many hospitals, many people saw her, she spent a lot of money. So that was different, that wouldn't have happened.
I think, sir, in an ideal world, I see, first of all, I'm just thinking, because Dr. Manoj told us that he had joint pains before our presentation. And I was thinking, can any infection present exclusively with joint pains? Unless proven otherwise, most joint pains are autoimmune or immune mediated. So, I want the healthcare system to be competent enough to recognize that joint pains indicate autoimmunity and act faster perhaps. So, I maybe then wouldn't pivot on the SSA, SSB, Sjogren's antibodies. So, autoimmunity is striking loud through joints. That's what I think.
So I think you made a very valuable medical cognition point here about medical cognitive markers of diagnosis. I mean, I don't think anybody said this, but medical cognitive markers are essentially bioclinical markers which give you a hint of the entire picture, and you can make a diagnosis based on that. I mean, it's just a pattern. I mean, you can call it catastrophic APLA just because the patient has died of this autoimmune disease which causes vasculitis and thrombosis and is associated with one antibody which got discovered in 1960s by Hughes. Hughes syndrome they used to call it before we changed to APLA. So this pattern has been well terminologized, like given names, but as far as the disease and outcomes are concerned, we haven't moved much. Since we discovered adrenocortical hormone as a good immunosuppressant, and of course a lot of synthetic adjuncts, I don't think we've moved much in providing for these. And essentially we are looking at the unknowns here and the opportunities that your generation is going to have when solutions start coming in, especially because of medical cognition endeavors, where you try to sort out where we can improve.
I think that is where optimization comes in, sir, where from whatever you know, whatever available, you just go ahead and treat your patient.
So over to Haripriya. I'm now taking the role of Dr. Haripriyya to announce the next. Yeah.
She would like to continue her second case, sir.
One more case, sir, which is another thesis case.
46-year-old female, a resident of Nalgonda, came in a confused state with the casualty. 2 episodes of involuntary movements of upper limbs and lower limbs and cough with bloody sputum since 1 day. GCS at presentation is C4, B4 and M5. And coming to the course of her illness, in 1998, she initially developed low backache and on routine investigations, she found out like her baseline creatinine was elevated because she was using like pain medication since then for her low backache. And on investigation, they were told that there is a soft tissue encroaching on her spine, so that they asked for surgery, but they refused for surgery. So she was on painkiller since then, and so she developed she has raised in creatinine level since then. And in June 2022, she has fever, cough and SOB, for which she got admitted again. And then in view of acute kidney injury, she was dialyzed and she underwent her first dialysis in June 2022. And in July 2022, she has similar swelling of bilateral lower limbs. And in September 2022, she developed fluid-filled blebs in her both upper limbs, and her nails got eroded and detached. There was a detachment of her nails. And there was a hyperpigmentation over her skin, and there was itching over her palms, and there was a fever, and there was decreased appetite and alopecia, and she was then diagnosed as anti-synthetase syndrome. And in December 2022, she has cough, which was non-blood stain, and bilateral lower limb swelling and decrease in urine output, and there was a shortness of breath of grade 3, and there is loss of appetite, and on HRCT chest was done, and bronchoalveolar stomach was also done, and which showed invasive aspergillosis. And in view of worsening renal parameters, December 2022, she underwent her second renal dialysis. And in January 2022, when she was admitted in the last year, sir, she developed she has a presentation like status epilepticus by involuntary movements of upper limbs and lower limbs, and cough with bloody sputum. And initially course in the hospital, we intubated her, she was intubated, and she was started on midazolam infusion, and she developed post-intubation case was arrested, and CPR was done for 5 minutes, and after spontaneous circulation was achieved, and then midazolam infusion was continued, and she was started on conservative management and taken to dialysis. And then she developed hypoxic ischemic encephalopathy. And coming to head-to-toe examination, she developed hyperpigmented lesions over the face, upper limbs and neck. These were the hyperpigmented skin changes. And then her nails got eroded. And CNS examination after sedation.
Just to clarify, those hyperpigmented changes appeared after central line insertion?
No sir, previous day only.
Okay, so when was this change detected?
Sir?
When was this change detected?
Immediately after presentation.
Okay, and the previous image was taken when? I'm assuming you put in a central line for dialysis.
Yes sir.
Yeah. So when this change is noted after?
No sir, previous day only.
Okay.
And after sedation, her meningeal signs were absent, and pupils were mid-dilated and reactive to light. Dorsal is present, and reflexes and corneal conjunctival reflexes were present. And deep tendon reflexes, biceps and triceps were elicited, and other reflexes were absent. And other system examinations were normal at that time. And coming to provisional diagnosis, we thought it as status epilepticus, secondary to seizures, secondary to hemorrhagic stroke, or autoimmune vasculitis, and or metabolic cause. In the background of CKD, we thought it to be a increased urea, and immunological flare-up as we stopped her immunosuppressants 1 month ago. And MRI brain was done. And coming to summary, this is a case of 46-year-old female with a background of chronic kidney disease since 13 years, with autoimmune involvement. She has got her ANA tested and it was positive, and we thought the organs involved are skin, nails, lungs and liver. with current complaints of seizure due to posterior reversible encephalopathy syndrome. And current complexities in that patient were during at that time there is a difficulty in weaning off from the ventilator, and there is no improvement in GCS, and there is delayed recovery. We thought it because of the cerebral insult due to CPR, sir. And she has severe anemia and refractive metabolic acidosis at that time. And coming to discussion, between persistent vegetative state and Lodgkin syndrome, there will be arousal in both the states, but there will be no awareness in persistent vegetative state. And eye opening will be present in both the cases. In apnea, like coming to patient can take breath spontaneously in persistent vegetative state and Lodgkin syndrome. And the brainstem functions is preserved in both the cases, and hypothalamic function is also preserved. And coming to body movements like facial and vocal expressions, there will be a motor activity in persistent vegetative state, like there will be a non-purposeful movements, inconsistent and non-coordinated. They can occasionally smile or cry, but in Lodgkin syndrome there will be just eye movements will be present. And coming to the organs involved in her, spine is involved initially, and kidneys are involved, there is a CKD in her, and lungs, when she developed cough and SOB, her HRCT was done, and which showed there is a left lower lobe consolidation, and there is a peripheral ground glass apostosis, and there are also septal thickening, and there is a pleural effusion, and there is also splenomegaly, and there are skin hyperpigmented skin changes are seen. And coming to the liver parameters are derange, sir. We thought it as autoimmune hepatitis. And in peritoneum there is ascites was previously she is having a history of ascites also, sir. And coming to brain involvement by seizures secondary to autoimmune vasculitis. PET-CT was done outside, sir. And coming to new onset generalized convulsive status epilepticus, in this patient it could be due to posterior reversible encephalopathy syndrome, or it could be due to septic encephalopathy, or it could be due to uremic encephalopathy. And we can diagnose based on clinically on MRI findings. Clinically, there will be visual disturbances, headache will be seen in 25% of the cases, and seizures will be seen, and there will be impaired consciousness. MRI findings will be seen similar to there will be features of cerebral edema will be seen, sir. And coming to background history of hypertension, immunosuppressive drugs, sepsis and autoimmune, these can cause breast. And these are the MRI images seen in pressure, but these are not of patients. And coming to status epilepticus can be due to alcohol withdrawal, it could be due to electrolyte disorders, or brain tumors, cerebral damage, or encephalitis. This is the same pathophysiology due to elevated arterial pressures, due to cerebral hyperperfusion, there will be an autoregulation overcome, and there will be a blood-brain barrier leakage or dysfunction, which can lead to vasogenic edema. Or it could be due to cytotoxic injury or endothelial dysfunction, which can also lead to vasogenic edema. And we thought it as actually she was diagnosed as antisynthetase syndrome in outside hospital, sir, because of the interstitial lung disease she developed, and she is also having inflammatory myositis and arthritis. In her hand, mechanics hand, but Raynaud's is by history they are not telling it as Raynaud's phenomenon, sir. And she has unexplained fever. These are the antisynthetase antibodies. Anti-Jovan is positive in this patient, sir. And anti-Rho, SSA and anti-KU antibodies are also positive. And this is a diagnostic criteria of antisynthetase syndrome, that is Corner's criteria. Clinical criteria: Raynaud's phenomenon, arthritis, ILD, fever non-attributed to other causes, and mechanic hands. And this is Solomon criteria. Major criteria are ILD, myositis, and minor criteria are arthritis, Raynaud's phenomenon, and mechanic hands. In this patient, the major criteria ILD is fitting, and minor criteria there is arthritis and the possible mechanic hands are there. And coming to lupus vasculitis. Lupus vasculitis, it could be dependent on the size of the affected vessels and the sites involved. Usually it can involve like different system, like it can involve the vessels affecting like nervous system. It could be nervous system vasculitis. They can have seizures or cerebral ischemia or hemorrhage, and it can be pulmonary vasculitis. If the pulmonary vasculature is involved, there could be alveolar hemorrhage, and there could be GI vasculitis, retinal vasculitis, coronary vasculitis, renal vasculitis, and cutaneous vasculitis. And this is a pathogenesis of SLE vasculitis. Usually in SLE there will be altered B cell and D cell response, and there will be immune complex formation. This immune complex formation, it can lead to increased vascular permeability. So there will be a complement activation which can release cytokines. These cytokines can also attract chemotactic attraction of polymorphonuclear PMN cells. And there will be a release of lysosomal enzyme, collagenase and elastase. And there will be a vessel damage also. It can lead to hemorrhage or ischemia, like by traumas or clot formation, and it could be caused for altered sensorium due to hemorrhagic or ischemic stroke. And this is pathophysiology of septic encephalopathy. As you all always know, like sepsis can lead to release reactive oxygen species. It can cause oxidative stress and cytokine storm, which can directly act on the brain, and it can cause neuronal damage. Like it is inflammatory mediators like TNF alpha and interleukins can cause blood-brain barrier impairment. It can cause imbalance in dopamine, serotonin, and acetylcholine, those neurotransmitters, and it can cause encephalopathy. And this is hypoxic ischemic encephalopathy. Due to decrease in blood supply, it can further cause ischemia leading to encephalopathy. Autoimmune vasculitis, similarly the reactive oxygen species and other inflammatory markers can cause endothelial damage, and it can also cause hypercoagulability state leading to ischemia, causing ischemic stroke. And it can also cause remodeling and injury, release of elastase and enzymes, which can lead to disruption of the endothelium, and it can also reach to hemorrhagic stroke and leading to encephalopathy. And this is my thesis cases, sir. Out of the 30 cases which I have studied till now, which I have seen till now, infectious, and coming to infectious and non-infectious, TB, meningitis cases were 3, and viral were 3, and parasitic, one case is a case of cerebral malaria, and other are non-infectious like hyponatremia, altered encephalopathy, altered sensorium secondary to hyponatremia, hypoglycemia or hyperglycemia, uremic, hepatic, and hypoxia, and other related to alcohol and septic or file. Like in cutaneous vasculitis, we can see purpura, pedicay, urticaria lesions, papillonodal lesions, and bullous lesions. And nervous system vasculitis, like brain microinfarctions can lead to inflammatory vasculitis, which is usually rare, but it can lead to involve peripheral and central nervous systems. If involved the central level, there could be a cognitive dysfunction, demyelinating syndrome, cerebrovascular disease, and seizure disorder. Thank you.
Now we request
Just a few quick queries regarding this case. Is it okay? Do I have time?
Yes, sir.
Okay. You are the moderator. But I can't breach protocols. So, what do you think is the likeliest diagnosis of her seizures? Just pick one. Likeliest diagnosis of her seizures.
Autoimmune vasculitis. in the background of she's on immunosuppressant, sir. As we can see, press is the most factors favorable towards press are
Just pick one.
autoimmune aspects.
Okay, so given that she had a background of chronic kidney disease, would you expect her heart to be functioning fully well, or do you expect it to be damaged? Yeah, so I would expect coronary artery disease at a bare minimum in chronic kidney disease. 13 years, right, CKD? So, is it possible that she developed an arrhythmia and had seizures?
But at the time of presentation also she's having seizures, sir. But then
Yeah, I'm saying she had an arrhythmia at home. And is it possible that she required CPR because of another arrhythmia? And I think common things common. I am assuming the heart is the likeliest culprit here. So she had ROSC, but she had arrest, right? Post status epilepticus. So if status epilepticus itself is a precipitator of arrhythmias. So is it possible that she may have had arrhythmias or VPIPs or VTACs, whatever, which led to all these events, more than a slightly uncommon one called autoimmune vasculitis?
so but during we were there only, sir, but we couldn't appreciate it on a monitor or during the time of the arrest.
So arrhythmia as
Yeah, but you were there during the time of the arrest, but not before the arrest, and what the monitor showed may not have been picked up before the arrest.
even 7 seconds, 6 seconds is good enough to precipitate a crash. So the 6-second window is very short. But autoimmune vasculitis is wide. What are in favor of autoimmune vasculitis?
In the background of autoimmune condition, there is a quite possibility.
But the background also says CKD.
Yes, sir, she is having
What was the reason for a CPD to begin with? 13 years.
low back medication for her low back pain.
Yeah, just NSAID, CPD.
I think since 1982,
1998, sir.
No, I'm talking about some literature here, I'm sorry. So since 1982, when phenacetin was the first generation NSAID which was implicated in interstitial lymphitis. But since then, Voverons and Hyphenax or Aceclofenax, they are not implicated in CKD as far as I reviewed the literature. So, are we pivoting on an assumption here that the NSAIDs are the cause of CKD? I believe so. But what do you think?
We are thinking that as NSAID inducer, but we are not sure whether it's
Like, what does NSAID do to the kidney to cause renal insufficiency? Does it cause any permanent architectural changes, or is it just vasoconstriction, which is physiological?
vasoconstriction.
Yeah, that is physiological, by altering the prostaglandin pathways. But do you expect a chronic architectural change in the kidney due to that? I mean, I'm just asking because probably there's not much literature. There's a lot of literature which are all negating each other and ultimately getting neutralized. So,
I think the NSAIDs are much more common because stochastic effects or allergic interstitial nephritis or something of those sort, rather than progressive CKD. I think I've seen about 7 members in my family who are on ketorolac since the last 15 years, and their creatinine is 0.6 average. So I'm not really convinced with the idea of, even in first year PG, so it's not like I've grown horns here. So even in first year PG, I wasn't really convinced with NSAID induced nephropathy. You can agree to disagree, but
no, I think it's a very valuable point because it's a very common assumption as soon as a patient is brought in and we talk about, the drug-induced kidney disease. I think it's a very common assumption we tend to make, and we have to break this with whatever horns.
RL causes hyperkalemia. There's plenty, sir.
Yeah.
So,
And we have 2 pharma PGs here, by the way. So would we like to give their inputs on this from a pharmacological perspective?
Morning, sir.
Sir, NSAIDs, as far as I know, they produce prostaglandins and that causes the vasodilation, and that can cause acute kidney injury and interstitial nephritis. So maybe long-term usage can affect
If you just average natural history of patients with interstitial nephritis, I think they have polyuria, non-uric renal failure.
Yes, sir. Previously it was not.
Yeah.
Sir, but now how can we explain that renal failure, sir, on retrospective analysis?
That's a good
What
question.
would be
Yeah.
the cause for her?
How old was she when she had it?
Sir,
How old was she when she had it? 13 years back. Because of her age.
I think SLE.
SLE to begin, will it first begin?
You also said she had pleural effusion and ascites.
Yes, sir, but
I was thinking polycirrhosis at that point, which is hallmark. I mean, I won't say hallmark. I'm scared of using those words now.
but it started after years, no, sir. Initially, the presentation was 1998.
Exactly, which is the very point of my presentation, is that she has a unique narrative. She's not standard SLE. Her SLE is different from my SLE or someone's SLE. So her narrative, but if you look at the big picture, multi-system inflammation, why not? And was she using protein? Did she have proteinuria?
Yes, sir, she's having protein.
Did you do a TAP, SIT TAP?
No, now at the time of presentation, she's not having ascites, sir. Previously, she had history of ascites, sir.
And you also mentioned splenomegaly.
Yes, sir.
Yeah, so that would pivot it in favor of portal hypertension. And if portal hypertension with those nails and lungs, I was thinking a rare disease called dyskeratosis congenita, but again, it's all. So, are you satisfied that this is autoimmune vasculitis? Right hand to your heart.
But as I haven't seen so much cases, I'm not sure.
Yeah, I think only sir can weigh in here.
So she was satisfied earlier, now you made her dissatisfied. And that is the purpose of medical cognition. Make you all dissatisfied, uncomfortable, so that you start thinking. If you're satisfied, you go to sleep. So we want you to be awake, arise. And with this, I'm thinking, the next one is Aditya's the real talk. But before that, should we break for tea or something to make ourselves more awake?
Yes sir, we should.
So shall we do that? I mean, it's all up to them, of course. Protocol.
Yes, sir.
So after that, we'll be more refreshed for his talk in the subsequent months. So let's break for tea. Without sugar, hopefully.